Yeah, Professor, we're live right now. And good morning, everyone. My name is Rodolfo. I am president of the Brazilian Association of Cardiothoracic Residents. I would like to present Professor Christopher Caldarone.
Great. Hi, Rodolfo. Thanks for inviting me here, and I'm looking forward to sharing some perspectives and lessons learned with regard to training in congenital heart surgery. I hope your colleagues will find it useful.
Thank you. Professor, you are Professor Christopher Caldarone. He's a chief of Texas Children's Hospital in congenital heart surgery, also professor and of the Department of Baylor College in congenital heart surgery. Thank you very much, Professor, for your presence. It's a pleasure to have you here. Thank you. Feel free to start at any time as well.
Okay, so some perspectives and lesson learned in training. One, in terms of your goals as a trainee, I think what you really want to do is you want to learn a trade. You need a solid foundation of clinical knowledge. You want to accrue as much experience as possible. And you want to be in a program with progressive responsibility where at the conclusion of the program, you feel fully ready to go to take care of patients independently. That's the ideal. And the only way to get there, of course, is to train. So many of you have probably heard Malcolm Gladwell's book about 10,000 hours being required for becoming an expert in anything. He actually refers to work done many decades before, where they talk about chess, and they say there are no instant experts in chess. A master spends perhaps 10,000 to 50,000 hours staring at chess pieces. And if you do the math and you were to pick something right between 10,000 and 50,000 hours, if you're working 10 hours a day, 35,000 hours is about 10 years. So that's a long time. So what you want to do is increase your time efficiency of learning, and the concept of deliberate practice is there. One way to bring deliberate practice to your training, I think, is to number one, make decisions. And it's very easy during training to just kind of lapse into a coma and just kind of go along with the flow and take care of the patients, doing what you're told and following the algorithms set up by the institution. But what I'll challenge you to do is to make decisions publicly. And what I mean is, in any clinical scenario, state publicly what you would do. It's that act of putting yourself on the line that gets that extra increment of learning out of every experience. And of course, some decisions you may not want to make publicly. It may be socially inappropriate, but you can always be making those decisions privately in your own mind. Under these circumstances, I would do this. And then you can watch and see what actually happens. If something different happens than what you would have done, you get to learn about the alternative pathway. If your pathway is followed, you get to see what would happen, but it's putting yourself on the line, making the decision that's important. The second way to increase your efficiency during your training is to keep a log. It sounds like such a simple thing, but the act of writing down what you did is very important. Probably many of you already do that. One of my co-residents when I was training actually always put an emphasis on drawing. He always drew diagrams of every case, and his rationale was if you can't draw it, you really didn't understand the anatomy. And I think that's actually valid. I can't say that I've drawn a lot of my case reviews, but many that I have, I go back to those diagrams many, many years later, and they're still helpful. So it's a useful exercise. Finally, ownership. You need to own your own education. You can't really expect a program to educate you. It's about you owning it. And I think another way to increase the efficiency of your training is to really own your service. And I don't just mean your patients, I mean every patient in the hospital in your program. You need to own them. You need to know every detail about every patient all the time. Try to beat your staff to the important data. Bring it to their attention. Become quietly indispensable on the service. I say quietly indispensable because that's the best way to ensure your success in your training. If you're loudly indispensable, well, you'll just irritate people, but you'll be right. If you're loudly dispensable, you're going to get fired. If you're loudly well, I can't remember the fourth variation on the theme, but quietly indispensable is the best way to roll. So I can tell you a little bit about the current system in the US for congenital heart surgery training. In 2006, the ACGME accredited its first congenital cardiac surgery program. By 2020, there's roughly 12 ACGME accredited fellowships, but it varies every year due to the program intake. There's three variations on the theme. There's programs with a strict one-year fellowship. There is potential for programs to have a two-year fellowship, although I don't think any of them do that right now. And there's also a one-year fellowship that enrolls every second year. And that's actually, I'll tell you a little bit more about that strategy. If you look at training paradigms across the world, there's two different paradigms in the US, different ones in the UK, Canada, Australia, Spain, Latin America. The point of this slide is there's a lot of variability in the training paradigms, which indicates that there's no sure best answer for how you should get your training in terms of time allocations. There's some significant problems with the ACGME program, I believe. And that is, if you are this new applicant here, you're going to try and get through a bottleneck to get your training. But you're going to be competing with a lot of other applicants, and only about 12 a year are actually going to get through. And typically it's less because some programs have internal candidates. Some programs don't enroll on one given year. So it's 12 or less every year are going to get through, and there's a lot of applicants. So the unsuccessful applicants get into a problem, and they are often highly talented. The palette of applicants that we have here, which is basically the same group that goes around to all these programs, they are outstandingly talented, but only a few can get in. So these unsuccessful applicants face this terrible dilemma of what should they do? Should they try again and gamble a year of their life waiting to go through again and hope they get through the bottleneck? What are the odds that they're actually going to get through? Are they going to have higher probability of success because they're one more year in terms of experience? Or after 2 years or 3 years, are they going to start looking bad on the application and actually diminish their chances of getting in? This is a terrible dilemma, and my heart goes out to the applicants who don't get in. They are nearly all deserving. So one thing that they can do is they can quit and just opt out of congenital heart surgery as a whole. Or they can do some other ways of getting into practice. One, they can take on a mixed practice, which is a non-ACGME approved job where they're taking care of congenital heart patients, but also managing a non-congenital practice as well. And indeed, that's what I did when I moved to Iowa for my first job. I was the chief of congenital heart surgery in Iowa, which meant I was the chief of one. But what I really was doing was a lot of coronaries and valve work, aortic work, et cetera. And that was all very valuable. And over the years, I could shift into more and more strictly congenital practice. Right now, that is a harder job to get because often they need the ACGME accreditation to take these jobs. But there are jobs out there, though, where you can do this mixed practice and then slowly drift into full congenital. Selective congenital is kind of a variation on that theme. And of course, you can get a job in a non-congenital role where you are doing adult cardiac surgery, but you can take advantage of the skills you learned in terms of valve reconstructions and aortic work, et cetera, and apply those in your practice. Perhaps a big Marfan's practice, can take advantage of congenital skills and not strictly be a congenital job. So has this been a success? Carlos Miri, one of my prior colleagues, sent out 50 surveys, got 35 responses. Interestingly, among recent graduates, 91% did not feel ready to engage in solo practice. 97% considered mentorship in their first year of practice very important, but 40% of those who were in their first year of practice actually felt the mentorship was poor or inadequate. And if you look at open-ended comments in the survey, about half of the patients felt that 1 year of training wasn't sufficient. So this is a little depressing, but what it really means is it's a long, steady, slow, and uphill pathway. And if you stick with it, you can do well, but it's not, one should not have the feeling that once you finish your formal training, you're all of a sudden ready to go. It's a long uphill climb. This is the way it works at Texas Children's Hospital. We have one of those 2-year programs that enrolls every other year. And we have 3 components of the program. One is a lead-in interval, where you serve as a clinical instructor, you develop your clinical skills to optimize your fellowship, which is the next phase. And you can get involved in some research too during that time if you want to. The proper ACGME fellowship is an accredited interval. It's 12 months, it's fixed. You have to meet your case volume requirements during that 12-month interval. And then there's a follow-up period, a mentored interval, where you're an instructor, you can operate independently, and you may want to spend your time selectively focusing on VADs or cardiac transplants or ACHD, and you can consider this a finishing school. But what's nice about the way this is organized is we can change the intervals to tailor it to the individual trainee. The 12-month ACGME fellowship cannot change. That has to be 12 months consecutive. But we typically go 6 months to kind of get used to the system, break yourself in, and then start your 12-month accredited fellowship, followed by 6 months of mentored instructorship. But if you need a little longer to get up to speed, we could stretch that up to 9 months, for example. If you arrive here and you're already very proficient, maybe only 3 months, and then you're 12 months, so that you can have 9 months of the mentored instructorship at the end. So we try to tailor it to the trainee. Only one trainee has actually gone through this, and he got a job here in Houston. And our second trainee is in this process right now. So on the other side of the training paradigm, it's worth a few minutes to just talk about what are the challenges the teaching programs face, because if you understand the problems the program is facing, you can better figure out how to navigate your own career. One important point, at least in the United States, is the pressure of public reporting. Public scrutiny of our outcomes has never been higher than it is currently. And frankly, one can simply not accept diminished performance because of unsupervised activity. When I was training as a resident, it was okay to have a resident-run service where outcomes weren't quite as good. That is no longer acceptable. So there's a difficult balance teaching programs face between balancing autonomy for training purposes and safety, which is of course paramount for the patient's perspective. And this balancing act is difficult. Another challenge, junior staff are starting now because of the current training paradigms with a bit of an experience deficit. They aren't, as you can see in that survey, they aren't fully up to speed. So the junior staff needs simple cases, but the senior surgeon also needs to take simple cases to teach the new trainees who haven't become junior staff yet. So there's inevitable competition for the availability of these cases that has to be balanced by the chief. Another challenge, international programs have been excluded from the ACGME process. And I think this was a big mistake by the American board. Highly respected international sites have been excluded from ACGME training, including Sick Kids Toronto, where I did my training, Great Ormond Street, Melbourne, and many other international sites. It doesn't mean that we can't train there. I think what's going to happen is people are going to finish their ACGME training and then go to one of these sites for some additional training as a finishing school. Another challenge for teaching programs is to get their head around the rising importance of non-technical skills. And this is, I think, becoming one of the dominant issues in training of surgeons. And by non-technical skills, I'm talking about, what the aviation industry basically figured out is that human behavior is a dominant source of error in complex systems. And this has an important impact on outcomes. And the idea of these non-technical skills, which focus on human behavior, can be applied to cardiac surgery or any surgery for that matter. And this isn't a new idea by me. This book here, I'm going to advise every one of you to go out and get. It's an easy read. It's a great book, and it'll open your eyes to this world of non-technical skills for surgeons. Perhaps you're already aware of this, but the book really focuses on basically describing in detail a conceptual approach to situational awareness. What does that mean for you and for your team? Decision-making, not straightforward. There are many nuances of decision-making that are influenced by human behavior. You can get some important insights with this book. Communication and teamwork and leadership. These aspects of surgical training have never been more important. And frankly, I think these are the aspects that differentiate the successful surgeon of today, as opposed to when I was training in the 80s. In the 80s, mostly, I think you needed technical skill. There were a lot of real jerks out there who had no concept of communication, teamwork, and leadership, but they kind of got by. Now, the technical skills are just as important as ever, but they're more easily obtained. It's the non-technical skills that are becoming more important to differentiate the successful surgeons. And part of the reason the technical skills are more easily obtained is a good example is our meeting here today. I'm speaking with, I don't know, dozens, hundreds of people immediately, very easy access. When I was training as a resident, people would fly around the world and stand on a stool behind the surgeon, peering over their heads, trying to write in a little notebook of what they were seeing with a poor view. And they'd spend weeks doing that and then fly back to their program and try and share their notes and share what they learned. Now, if you Google mitral valve repair on YouTube, you can get 30,000 hits. Someone can do a great operation and share it with 1 billion people the same day. So I think the technical skills are becoming more easily to get. It's the non-technical skills that are going to differentiate you. So the ideal program is going to be a program where you have ownership of your patients, you are able to own your education, you have an appropriate service to education ratio, you have some graded responsibility with clearly defined objectives at each stage in your training, and you have an institution-wide culture of teaching skills, including non-technical skills like leadership and communication and teamwork. I think that's the ideal program. So I'm going to shift gears now and talk about something completely different. And this is things I wish I had known when I was a trainee. And I'm going to share these with you, and I hope you'll find them interesting. This is all I got. There's nothing left after this. So 3 rules of survival. This is what I came up with when I was a resident. The 3 rules of survival as a resident. And the first one was respect your ignorance. It is profound. And the sad fact is your ignorance will only blossom and grow with time. What happens is your ignorance becomes less obvious to other people, but more obvious to yourself. So the other important thing about respecting your ignorance is you don't know who you can learn from. A good example for me was walking on the ward, and the ward clerk who was, transcribing the orders in the chart on paper with a pen, which of course a lot of programs don't do anymore. Probably the least educated person in the ward said, "Dr. Caldarone, you should go look at Mr. Smith." Now, it would be quite easy to be arrogant and say, "What are you doing telling me who to look at?" But she knew something was wrong with Mr. Smith because she was transcribing orders all night and she knew there was a problem. My point is, you don't know who you can learn from. Rule number 2, never count. Anytime you're counting, whether it's the years you have to go till you're finished, the days you've been on call, the hours you have been awake, the number of nights you have to go until you get a weekend, anytime you count, you're going to disable yourself in terms of achieving what you could. Don't count ever. And this was important in the 80s, always carry something to read. Of course, now you have it on your cell phone, so maybe it's not so important anymore. All right, 2 truths about everybody in healthcare. There's 2 things you need to know about every single person in the hospital. And number 1 is everyone thinks they're doing a good job. Even if they're not, they think they are doing a good job. That's how they sleep at night. And everyone wants to do a good job. Now, these are slightly different, and there's a little tension between them, because if you're going to propose how someone could do a better job, you're threatening the fact that they already think they're doing a good job. And if they don't want to go along with what you say, then you're threatening the idea that they want to do a good job. You're saying that they're lazy. So if you want to get someone to take care of patients in a different way, you have to be really careful that you don't threaten one of these 2 beliefs. If you do, they will come at you like a cornered rat because you're threatening their identity. But if you can find a way to work within these 2 truths, you'll be able to show people better ways of doing things, and they will follow. All right, how do you go to sleep at night when you had a bad outcome in your hands? You're going to have to manage this in your own life for the rest of your career. So what you have to do is you have to avoid committing one of the 3 unforgivable sins. The unforgivable sins, number 1 is lying. And lying comes in many shapes and forms. There's outright lies, but then there's also lies where you really duck responsibility for something that you were involved in. You really don't relay to the parents exactly what happened. You really don't relay to your colleagues what happened. All those are forms of lying. Number 2 is being lazy, not getting out of bed when you should have, not following up and doing what you should have done. And you know when you've been lazy. And number 3 is not calling for help when you need it. If you can avoid committing these 3 sins, no matter how bad the outcome, when you're lying awake at night, just roll over and go to sleep, because this is the best you can do. You can't always guarantee a good outcome, but you can guarantee that you won't commit one of these 3 unforgivable sins. And that's how you can sleep at night. All right, 6 criteria for academic leadership. Dr. Williams was a great academic leader in Toronto. Dr. Levitsky was. I watched a lot of great leaders over time, and I tried to come up with what are the criteria for academic leadership. And this is what I came up with. Number 1, you have to work harder than anybody else. First in, last out, all the time. 2, you have to clearly define your brand. Now, people in your program have to know what you're all about in very few words, 2, 3, 4 words at most. And they have to know what's important to you and what you're all about. 3, you have to be pretty good at your trade. You don't have to be the best in your program. Certainly, I'm not the best here, but good enough that people are willing to ask you for advice and you have credible opinions. 4, you have to silently work for the success of those around you. The better they do and the less you're noticed, the better you're running your program. 5, you always take the hit. Anytime things go wrong, you fight for the responsibility of that bad outcome. And now this is very interesting what happens. If you always fight for responsibility and take the hit for a bad outcome, what happens is everyone else starts doing the same. The exact opposite is true. If you duck and bob and weave every time there's some bad outcome, everyone else does the same. So you got to own everything bad. And number 6, you got to respect your visibility. People are watching you, and I mean you all right now, even as trainees all the time. You are leaders in your hospital, and people watch and they pay attention. You can do a lot of damage and not even mean to A gesture with your eyes, taking out your cell phone at the wrong time, a shrug and a sigh, walking out of a room quickly. Those gestures can be taken as severe criticism, and you can do a lot of damage to people. On the other hand, you actually have a lot of power, because an unexpected positive comment, a pat on the back, a recognition of some work well done, you can actually push people along and really drive their careers forward too. So respect your visibility. For the rest of your careers, people are always going to be watching you. One rule for communication: never, ever, ever, you probably know what I'm going to say, use email to solve a problem with emotional content. It will not work. No matter how well you articulate what you're trying to think, it's going to be interpreted in a wrong way, and you're going to just make things worse, especially when you CC all with anything that's even close to criticism. If you have a problem with someone, your only email response is, let's get together and talk about it. How about this afternoon? And that's how you solve problems, in person, not by email. This one, pain is your friend. I think it sounds a little macho, but I think it's actually true. The more, so training is uncomfortable, working hard is uncomfortable, staying up is uncomfortable. This discomfort, if you reject it and try to make it go away, it becomes pain. If you embrace it, it actually is just another sensation, and it takes away the emotional content. So athletes do this all the time. They train to the point of having pain, but they embrace that pain. They like that burn in their legs or their arms or whatever they're doing. You can look at it the same way in your training. Embrace the burn. You got to burn to earn. All threats are opportunities. So this is something important too. The worse calamity that comes your way, the more opportunities there are. And I learned this in boxing. If you're trying to punch someone, you can't actually hit them unless they're willing to try to throw a punch at you. It's when the punch is coming at you that the opportunities come up to counter punch, deflect, whatever. But it's only when the threat comes at you that you can do something. A good example is the COVID pandemic. So it's created all kinds of terrible things, and it's awful, but some opportunities have arisen even in this terrible pandemic. For example, the use of video conferencing has absolutely skyrocketed. I think our rounds and conferences and daily patient rounds are better attended now that we've gotten used to this modality than they ever have been in the past. Who would have predicted that with a pandemic? But threats are opportunities. Anything bad that happens to you, if you can keep a cool head and look at it, just like a punch coming at you, you can figure out how to maneuver around it and turn it to advantage. All right, wishes are not plans. You're all going to make plans. You want to do something. You want to roll out a program. You want to lead a program. You want to get through, I don't know, some complex set of issues you want to deal with. If you want to make a plan, you have to have components of a plan. And this is what I use. If I want to make a plan, I figure out what the objective is, the rationale, why do I want to do it, the strategy, generally, how am I going to approach it, the tactics, what are the step-by-step things I'm going to do, logistics, what do I need to execute that plan, contingencies, what am I going to do if any one of those tactics fails, and a timetable, where do I expect to be at what date every step of the way. If you can't articulate all these steps, you don't really have a plan, and instead what you have is a wish, and wishes don't work. Persuasion. I always believed that the further up you go in the hierarchy, the more control you have over the people around you. And it's exactly not true. It's exactly not true. As a matter of fact, I spoke to a commander of a destroyer squadron in the US Navy who I invited as a speaker and said, hey, it must be so easy for you. All you have to do is order people and tell them what to do, and everyone does it. And he said, no, 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 absolutely not, even in the military. Because when you have highly motivated, highly capable people, you have to persuade them that a course of action is the right course of action. And then you can get buy-in, and then you get to harness their power, and you can really make things move. You can order people for about 10 minutes. You'll get, maybe in a crisis, people are willing to do that. But in general, you need to learn how to persuade people. Persuasion is much more powerful than direct control. This is one of the last ones, spectacular failure. My kids know all about this because I tell them this all the time. You want to have a big, public, spectacular failure every 3 or 4 years. Something you really put yourself way out on the line for, and you fail miserably, because it's not getting knocked down, it's how you get up that shows people what you're all about. And furthermore, if you're not failing every now and then, you're not really trying, you're not really pushing things. If you get used to the taste of failure, actually, you can do a lot better in your career. Just enjoy it. You just kind of wipe the blood off your lip and get up and move on. Last one, balance. Now, all this pain is your friend stuff and, spectacular failures all sounds pretty brutal, but on the other side, you actually have to balance your life, and you want to spend the time and invest in your family life, your extended family. And my last bit of advice is make sure every day you do at least one thing that you enjoy, even if it's short. Just, you got to have one thing every day that you enjoy. And if you can develop a good, wholesome family life, you should have the balance you need to get through a career. So that's all I have. Thanks.
Thank you very much, Professor. It's a pleasure hear this awesome and really important situations that ever cardiothoracic training resident need to have in order to become successful. So let me see. They don't ask any question now. I would like to thank you, Professor, for this awesome presentation. If you have any other subject to talk about, feel free.
All right. So, do I sign off?
No, yeah, just one question. What do you think about the congenital heart surgery in the future as not young, but also as adult? Since we can see there's less children born in the world, but congenital adult heart surgery is probably gonna grow more and more.
You talk about ACH, adult congenital heart surgery?
Yeah.
Oh, well, so, that's obviously a huge growth area. It's the fastest growing population in cardiothoracic surgery, no doubt. And I think that actually offers opportunities for non-ACGME accredited fellows to get jobs, because most adult practices have some ACHD component, and that could be your way to get a beachhead in the in a practice, and you could expand upon that. ACHD is it is a field unto itself, though. It's a special skill set. Those patients can unwind and deteriorate really, really quickly. It's amazing. They walk around for decades with physiology that justifies a transplant, and they say they feel fine. Well, they feel fine because they've been that way for decades. It's really remarkable.
Yeah. So that's it. Thank you very much, Professor.
All right, you're welcome.
My Have pleasure. A great day. Thank you very much.
All right, thanks. I'll see you.
See you. Bye-bye. Thank you.